The countdown.
We're live now, guys.
We're live. Okay. So, good evening, good afternoon, good late evening to all of you from whichever part of the world that you're tuned in. This is Dr. Rujuta Mehta welcoming you on behalf of the entire Bombay Orthopedic Society. As you all know, Bombay Orthopedic Society is completing 60 vibrant years of a very interesting and ever growing legacy that we have. And these worldwide webinars actually are a big dream for our president, Dr. Gautam Zaveri, who is, for some personal, unfortunate reasons, not able to join us now, but he will be trying something during the course of the webinar. And it was his vision that the expertise from all around the world, especially in a subject like arthroplasty, which has been a cornerstone for technology advances and a great deal of learning for all of us throughout our careers, and which has really changed over the years very drastically from what we've seen. To be able to distill out this wisdom with worldwide experts and to be able to offer it to all our listeners and watchers, right from postgraduates to experienced surgeons. And therefore, I think it's a very nice way to have this sixth webinar that we are doing today. And who better than Dr. Shubhranshu Mohanty, who's been our past president, and Dr. Mojieb Manzary from SICOT, two organizations and two stalwarts who have great deal of experience and would be able to bring out all the nuances in discussion with worldwide leading experts in the field of knee arthroplasty. So without much ado, I do not wish to stand in between you and your audience. I hand over the uh, mic to Dr. Mohanty to do the introductions of our elite faculty today.
Thank you, Dr. Mehta. It's greetings from Mumbai, dear friends, India, and good afternoon, good evening, late good evening to all of you. And this is a worldwide webinar on the combined effort of Bombay Orthopedic Society and SICOT. And today we have an eminent faculty both from the SICOT as well as Bombay Orthopedic Society. And on behalf of SICOT, may I invite Dr. Mojieb Manzary to give a short introduction. Dr. Vikas Khanduja, who is the president of SICOT, is right now in a flight, and his flight unfortunately got delayed. That's why he's unable to join. He has conveyed his apologies. And on behalf of Dr. Khanduja, President SICOT, I invite Dr. Manzary. Dr. Manzary is an adult hip and knee reconstructive surgeon and chief of orthopedics and adjunct assistant professor in the Johns Hopkins University and Johns Hopkins Armaco Healthcare Center in Dhahran, Saudi Arabia. And thank you, Dr. Manzary, joining today. He will be also, moderating this session along with me. Over to Dr. Manzary, please.
Thank you very much, Dr. Mohanty. And on behalf of Dr. Khanduja, I'd like to convey his regards to all of you. On behalf of SICOT, which is a world-class orthopedic society emphasizing on worldwide education, I'd like to thank Bombay Orthopedic Society for giving this opportunity of a joint webinar, which will highlight the different learning opportunities in arthroplasty. SICOT has multiple educational and learning opportunities, either in multiple webinars in different orthopedic specialties. We also have virtual training fellowships, and we have multiple workshops, like cadaveric workshops, that are commonly held in different parts of the world in different orthopedic specialties. So without due delay, I'd like to thank everyone from the eminent faculty from all over the world who took their time away from work and family to join us in this webinar, and wishing you all a wonderful hour of learning. Thank you.
Thank you, Dr. Manzary. Let me introduce our eminent faculty today. So first is, my good friend, Dr. Nicholas Buddhipharma, who is from Indonesia. Dr. Nicholas is a president of Asia Pacific Orthopedic Association at present. He's one of the 7 founding fathers of the International Knee Society, which was established in 2025. One of the initial 67 founding members since 2015 of the European Knee Society as well. He served as past president of Orthoplasty Society in Asia, Asia Pacific Knee Society, Asia Pacific Orthoplasty Society simultaneously from 2019 till 2022. Oh, that covered the COVID period entirely. And he has been honored as the 12th recipient to deliver the Effort Michael Freeman Honorary Lecture in 2024. And I think that's a great honor. And Nico, it has been a pleasure and honor to have you here. And thank you for joining today. In addition to that, I would tell my Indian colleagues that Nico is doing great philanthropic work in Pune in India. And he often travels, is a frequent visitor to India and great friend of India. Thank you, Nico, for joining today. Now, our next faculty is, Dr. David Liu from Australia. Dr. Liu is a hip and knee surgeon in the Gold Coast Center for Bone and Joint Surgery. He has been Fellow of Royal Australian College of Surgeons and Fellow of Australian Orthopedic Association as well. He has been Vice President of Orthoplasty Society of Australia in 2025 and Chair of Knee Orthoplasty Subcommittee of SICOT at present. And he has been Scientific Secretary of Queensland Branch of Australian Orthopedic Association from 2019 to 2023, and the Editorial Board of Knee Surgery and Related Research, Editorial Board on Orthoplasty, and Honorary Adjunct Associate Professor of Faculty of Health Sciences and Medicine, the Bond University, Queensland. We welcome you, David, today, and thank you for taking time out of your busy schedule. And it has been late night there, as I understand, and thank you for joining today. Or, the other eminent faculty from SICOT is Dr. Ali Al Belooshi, who is orthopedic consultant and president of Emirates Orthopedic Society and UAE AO Trauma chairperson. Dr. Belooshi, thank you for joining. Even after days of hard work, you could manage to join today, and welcome to this webinar. In addition to our three eminent faculties from SICOT side, we have three eminent faculties from India as well. Let me introduce Dr. Harish Bhende, who is a good friend of mine. He's a consultant orthoplasty surgeon at Lord Clinic, Rich Candy Sursusa and Khanduja Healthcare Hospitals in Mumbai. And Dr. Bhende has been instrumental in the teaching and training of orthoplasty in India. He started with that, and now we are seeing the outcome of the teaching and training in orthoplasty. He has been the past vice president of Bombay Orthopedic Society. Welcome, Dr. Bhende. Let me welcome Dr. Ashit Shah, who is a robotic knee replacement surgeon in Mumbai and attached to the various hospitals in Mumbai, like Fortis Hospital. And welcome Dr. Ashit Shah, and he has been an eminent knee surgeon, focusing entirely on the knee arthroplasty. And finally, last but not the least, Dr. Vidyanand Raut, our colleague and KM Ortho alumni. He has been ISK Fellow, CLEARS Fellow, and Ranawat Orthopedic Center Fellow also, and he has been practicing orthopedics and knee and hip arthroplasty in various hospitals in India. So thank you, friends, and welcome to this webinar. Now let me start with the first topic today in the webinar. The first one is that we start with certain topics which are controversial now in primary knees, followed by some topics related to the revision knees, and finally something about rehab and thermoprophylaxis. So which knee, whether it's a CR knee, PS knee, MP knee, medial pivot knee, medial stabilized knee, this intra-stabilized insert, there are so many kinds of insert which has come into the picture. So let me, start with David. So David, what is your take? What kind of knee you use? One particular type of knee, or you have a selection of knees that in particular case you prefer to use some kind of inserts?
Yeah, thank you, Dr. Mohanty, and thank you to the Bombay Orthopedic Society and SICOT for asking me to be part of this webinar along with some esteemed colleagues. Look, I think now in 2025, now that we're aiming for personalized arthroplasty, personalized alignment, reconstruction, I think we need to tailor the insert to the patient's anatomy and expectations and activity level and deformity. So I do use a combination of inserts according to the scenario. And in general, so I think it's nice to have a knee that gives you every option within the same system. And I think most modern day knee replacements allow for this. I think in general, in my young patients, I like to retain the posterior cruciate ligament. A couple of reasons. I think most registries do show that a posterior cruciate retaining knee has greater longevity, right? A lower revision rate in long term. So in my young patients, my preference is to use a CR type knee. And usually my preference now is actually to use a medially stabilized knee because I like the additional congruity of the medial side to give me the sagittal stability. So CR knee for my young patients and usually a medially stabilized knee. Now, having said that, I think there are not so much with the medially stabilized knee yet, but certainly with the medial pivot knee, there are still some question marks about the possibility of loosening after 15 to 20 years because of the increased constraints. So I still think we need to keep an eye on it, but that is my preference, young patient. For the more elderly patient, and particularly with the valgus deformity that is not correctable, that may have medial laxity, my preference is to actually do posterior stabilize in those patients because I think it's very difficult to balance a medial stabilized knee if you have medial laxity from a valgus deformity that is not correctable. So in those patients, then I will do a posterior stabilize. And I have to admit, when I do posterior stabilize, I actually prefer to do mobile bearing. I like to do a mobile bearing posterior stabilize, not for the posterior stabilize, but more so because, not because of the mobile bearing, I should say, but because when I use posterior stabilize, I like to control the center of rotation. So with a mobile bearing, I feel that it will rotate around that central post cam mechanism. So I know that's a long-winded answer, but in general, I like in young patients CR, but now medially stabilized. My more elderly patients or my valgus deformities or particularly big deformities, then I'll use posterior stabilized mobile bearing.
Yeah. Thanks, David. Harish, I know you are a PS user. You prefer to use posterior stabilized knee. Do you use any CR knees at all, or if you use anytime?
No. I was trained with PSNE. I am doing it for the last almost 25 years.
Why
And my
do you think
long-term
posterior
outcome,
stabilized knee
yes,
is
posterior
better?
stabilized knee. But I always use them with rotating platform because that is essential. Because in India, patient want high flexion. And if you want high flexion, it is not to squat down, but to sit cross-legged. And if you're sitting high flexion with a cross-legged position, you need to have a rotational mobility of the tibia when the knee is flexed. That is not possible in a fixed bearing unless you've got a extremely good amount of accuracy of placing the rotation of tibial and femoral component. The rotating platform gives you flexibility to get that tibia slightly little here and there, but still get a very good high flexion function for the patient. And in terms of longevity, I have got my patient who had done about say 20 years ago in 2000, 2001 and 2, and they are doing very well. I mean, I don't have any higher, evidence of failure rate. And there was no need to actually change to a CR knee. So
But
I haven't done CR knee actually. No.
because all these designs, they are evolved because of because of certain dissatisfaction of the patients. So do all your patients are satisfied with a PS knee? Do they have any
I
difficulty?
actually, yeah, I actually did a study and found out exactly how many people are the so-called unhappy souls. And there are about 8 to 10% people are not completely happy. The figure of 15 to 20%, I think, is overstated. If you get your balance right, that is very important. If you get your alignment all right, I don't have to go by exact mechanical. I deviate a few degrees plus minus based on how much varus or valgus it is. I don't completely correct it to a straight 0, 0, 0 mechanical axis. So if you undercorrect within 3 degree plus minus, I have used navigation for about 10 to 12 years. I use robotic now. So the accuracy to get the alignment right and balance right is much better that way. But if you get proper alignment, good balancing, I think these people, 90% of them are happy.
Yeah. Nico, that you also deal with Asian patients and those who want high flexion and all. So do you do this, alternative bearing surfaces or whatever, this medial stabilized or medial pivot, anterior stabilized, all these things?
Thank you, sir. If I add David and Harris like this, when I start about 40 years ago, I start with a PS. So that is my first message, especially because all of here they are the most expert, but then as you are beginners, I think it's better to use with a PS because it's more forgiving. And then by year, then you have a more expert because knee replacements operation is like an art, right? In the cruciate retaining, you have to be more careful with your release and everything. And if David is right, if you look at the starting in the joint registry in Australia, later in Holland and Finland, and now in United States, the TCR it's longer the survival rate compared to the PS. So that is number one. And number two is that I have to disclose that I'm one of the consultant for the developers of this middle pivot, and we published in the KSSTA 2 years ago. And I think personally, if you are because I'm half in Europe and I'm half in Indonesia, in Asia. So especially in Asian patient, they are very lax usually. So we have the advantage of using this middle pivot, especially with the anterior lips. So sometimes when you lax it, you can block it because you have a good perfect alignment, straight extension, but after 6 months, you can see that, hey, that's a start to have a recurvatum. And this is one of the advantages. And then in my study on middle pivot, that it is the patient feels it's more like a normal knee. And that is the difference because paradoxical anterior translations, but yet sometimes I'm a little bit biased. And again, when you ask about the hyperflex knee, hyperlax joint, laxity, flexion. It is not only on the design itself. It's a lot of things, right? The technique of operations and the rehabilitation post-operative.
Could you just a little clarify about is the medial stabilized knee and medial pivot knee, how they are different, they are same? There's a lot of confusion about it for the young orthopedic surgeons.
Right. So I will start like this. The design first is a middle pivot, right? After that. And nowadays there's a lot of this, we call it, they don't call it middle pivot, but middle stabilized. But I think it is almost the same philosophy.
Yeah. Okay.
So Dr. Mohanty, strictly speaking, medially pivot should be a ball and socket, one-to-one congruity on the medial side. The medially stabilized, which is what most of us would use now, is a little bit of a compromise. It is a much higher lip on the medial side, but not a true ball and socket. But I think the advantage of not going fully medial pivot is, as I say, there is a little bit of literature coming out now that perhaps tibial loosening might be a problem with a medial pivot because of over-constraint.
Can I make a point here, Shubhranshu?
Yeah, thanks, David, for clarifying the doubt. Now, Ashit, you are doing mostly robotic surgery. You are, with technology. Do you think that any of these, are more helpful with the robot or anything, or can get away with doing manual surgery also, or you have any specific indications for this?
For the inserts, you asked? For the
Yeah,
inserts.
yeah.
Okay.
We are talking
So,
only about inserts. Sorry.
insert, right. Okay. So when I started about 20 years ago, I was predominantly a PS surgeon, posterior stabilized for everything. Two unique problems we have in our country is the amount of deformity that we have. Secondly, the small size of the femur and the tibia, femur. That's where, the main thing is when we are doing a PS knee, we have to remove a big box. So we end up many times very, very small little bone. And then, sometimes when you're putting the implant, you may have a small little crack in one of the condyles of the femur. So this is one problem with our anatomy of our patients. So now, since we've been doing robotics for last 4 years, 5 years, I am able to get the gaps absolutely perfect to what I want, having a controlled laxity on the lateral side, which we normally require for a range of movement that Dr. Pende was just talking about. We need that good flexion movement. So now almost I've shifted from PS to 50% of my work has shifted to a CR knee, but again a CR mobile bearing. We have a CR mobile bearing implant in Attune, which is available. And with robotic surgery, I'm able to calculate and deliver the cuts and execute those gap management perfectly. So, which earlier used to be a bit of a problem doing the conventional instruments. Now I'm able to rectify that when I do the robotic surgery. So, majority of my work now is shifting, but still it is 50-50. I have also used medial pivot for quite some time during my training years when I was in UK, and that was a true medial pivot. So that's a ball end socket on the medial side, giving that medial stability and relatively flatter on the lateral side. So allowing that anterior posterior about 11-12 millimeter excursion laterally. So the true medial pivot, we've used, which I'm sure Nick has also mentioned about an excellent stability and excellent function, but the long term survivorship we'll have to see with interest.
Why did you stop then, medial pivot?
So it was, basically for logistics reason. It was available in few years. It was available in India, and then again 2016, I think so. They moved out. Again, they've introduced last year. So I've started doing a few again. So it was basically for the logistic reason and not for any medical and not for any technical reasons. So if it now it is available, and we obviously would look to using it for more and more number of patients.
Okay. Thank you. Let's ask Vidya, what's your choice of insert, and how do you prefer your patients?
Yeah, I am a PS person. Unless there is a compelling reason, I would not change to a CR. I always use a fixed bearing. Again, if I need to increase the constraint level, then I would prefer to use a mobile bearing, as the case may be. But most of my patients, irrespective of the age, would get a PS fixed bearing.
Okay.
And it has worked well.
Okay. Mojieb, anything you would like to add? I think.
Yeah, so I'd like to just sum up everything. I think a lot of this starts with what you have been trained with. During my residency, I was trained in both. Fellowship was strictly PS. Came back, I think 20 years ago or 23 years ago, we had patients.
Just 1 second. There is some echo coming out. Rishi, could you tell us, guide us? Somebody's microphone is on. Can you please mute
So
yourself?
if they're using two devices, then this tends to happen. So you can mute the other device.
Anybody using? No.
Yeah.
Okay. Now it's
Now
okay.
it's okay.
Yeah.
So I think
Oh, Mojieb, you are using
hello?
two devices.
I'm only using one device.
Okay.
Is it okay now?
Yeah, now it's okay.
Okay.
Thanks. Yeah.
So I think what has happened, at least in my practice, is that early on there were patients who were coming with much more higher degree of deformity. There was less and less acceptance of total knee replacement, I think, in Far East or Asian knees, because patients were demanding squatting, being able to kneel. And as they come very late, the deformity was worse. Obviously, the dictum was you start with a PS, because PS will allow you to manage those deformity much more, much more clearly and much more better. The two problems that I did notice, again, as Dr. Ashit said, that the smaller size femur, you are taking a big hunt, and that will be anything between 30–40% of the distal femur. You may unfortunately get either intraoperative fracture, or you may get a fracture when you come to remove these components at the time of revision, whatever the cause of revision was. Add to that the fact that when you're dealing with a PS knee, you're having slightly bigger flexion space compared to the extension space, so you got to do a good job of balancing. When the medial stabilized or medial congruent knee system came, the femoral component are usually CR, and that gives you the option of doing a CR component, but you can still have the option of either using retaining your PCL, or you can take the PCL off. It could be either a cruciate substituting or cruciate sacrificing, and relying much more on your inherent conformity from the implant itself. You can use it in the smaller size femurs, which we have a lot in elderly female patients. They're small size, they're small built, and they're very osteoporotic. So I'm not worried about cutting that box. If I'm not happy with the status of their PCL, I don't think it's healthy, I can take the PCL off, and it's actually a cruciate sacrificing, but I'm not taking the box, and I'm relying on the medial stabilizer, the medial congruent. For the very extreme deformity, I might still go with the PS, but my percentage of PS has dramatically decreased. I started using the medial stabilized in October 23, and I think by now 90% of my practice is predominantly CR femur with MC type of or medial stabilized type of insert, with the option of either retaining the PCL or sacrificing it, depending on how happy I feel about how healthy it is. Because what you don't want is that you leave that PCL, 6 months down the road, the patient comes with a ruptured PCL that was already arthritic and unhealthy, and now you're dealing with a flexion instability, and then going back to revise that knee within the first year.
Exactly.
And obviously, the chances, the incidence of periprosthetic fracture has remarkably low when you're not doing a PS type of box.
Exactly. Yeah. So to conclude, your friends, from
can
this
I just
discussion,
make one comment? Shubhranshu,
yeah,
let me.
quickly, because we are running out of time.
One thing
Yeah.
is, if you realize, in the beginning there was only CR knee and a PS knee. I am talking about 25 years ago. Okay, and since then, in the CR knee, there are multiple options of insert which you showed us. There is not so many options in a PS knee. Now, if you realize, as Nico mentioned, TKR is an art. Doing a CR knee is more of an art than a PS knee, because PS knee is more predictable because of the mechanical fixed rollback which it gives. So patients feel a definite more stability in the beginning. If you are not a very good surgeon, you may not do very good CR knee. Now, what happens is, if you start doing CR knee, in some of the cases, you may get a anti-rollback. Patient may feel out of sync when they walk. They may not feel comfortable. And to overcome the problem, you start changing your insert. So you get a deep dish insert, you get a medial pivot insert, you get a medial stabilized insert. You give any name, but you are trying to increase anteroposterior stability of that implant by changing the insert. So technically speaking, there are these drawbacks. So whether you do CR or PS, you need a stability.
Yeah, exactly. That's what we are discussing, and actually, you have given the gist of that. Before I moving on the next topic, just Dr. Ali, can you just tell what is your preference for this? What type of knee you use?
So first of all, I think if we look at the literature, looking between PS and CR, there is no difference in outcomes. If we look between mobile bearing and fixed bearing from the literature, there is no difference. So at the end of the day, it comes to the experience of the surgeon, his training, and his preference. So I was a PS surgeon, and with the use of robotics, I'm doing personalized knee with my tibia varus up to 5 degrees. So I don't like to keep my post kind of at risk of impingement. So this is why I switched to a CR. I don't have a medial stabilized poly in the component that I'm using now, but in the future, when it comes out, definitely this is something I'm going to consider, because you want to keep that medial stability, and if you want to sacrifice the PCL in severe varus cases, especially with flexion contracture, then you could sacrifice it and then keep the medial stabilized poly. Our cases in Middle East and Asia, they all in the past used to come, as Mojieb said, he's absolutely right. They used to present very late with flexion contracture, with severe varus deformity. You have to release the PCL. But nowadays it's changing. They are coming earlier. So I agree with David, for young active patients, why remove the PCL if you have full extension and deformity is mild?
Thank you. Thank you. So at least, to summarize this, that at least as a beginner PS knee, it's easier to do. So one can start with a PS knee, but now the world is moving towards more and more CR knee, and especially in young patient, bone preserving surgery, CR knee is much better probably. And if you have apprehension of losing the PCL and late, then you could use one of these anterior-stabilized knees, and medial pivot knee definitely provides better stability. But time will tell what is the long-term outcome of this medial stabilized or medial pivot knees. So let us stop our discussions regarding the type of insert here. May I hand over to Mojieb to generate discussion on cementless knees.
So we'll move over to fixation. And I think, although every one of us have done cemented knee, what about the cementless knee? Does anybody from the faculty do cementless knee?
In India, it's not available. So,
Not available.
Mojieb, despite me debating you many years ago, I do use some cementless knees. Look, for me, cementless knees are a very attractive option, but we still don't know the absolute, we still don't know exactly the best indications. I'm lucky I have patients who are big and have very hard bone. Someone must have a device because it's echoing. So I do use cementless knees in my young males with hard bone.
Ashit, could you mute yourself? Ashit. Yeah.
I do use it in my young males normally because they have harder bone. They're normally bigger. I think you do have to be careful. You have to have good enough bone. The biggest unanswered for me is, are these implants going to be compromised with alternative alignment? Because they were designed for mechanical alignment. And if you put the tibia and varus, you do increase the micromotion on the lateral side. It will lift. So we still have some unanswered questions as to how far into alternative alignment we can put them. But now I still like the concept of biological fixation in my young patients. Would also say is you have to warn these patients that actually they will be more painful and recover a bit slower than the cemented ones. And we showed that the PROMs take about 6 to 12 months to equalize between cemented and cementless. So you have to warn these patients they will take longer to recover.
So David, once that plateau is done, so once they have gone over the initial period of micromotion, they settled in, we know from the literature that the micromotion is far more less in the cementless compared to the cemented. Is there evidence that on long term or midterm, there's less chances of aseptic loosening in cementless compared to cemented? Is there any evidence?
So
I'm talking about the modern cementless knee.
Well, so modern we don't have enough data yet out to long enough, but that is the I guess the driver is that there is some evidence now that tibial radiolucencies, tibial loosening is less with a well-ingrown cementless tibia than a cemented.
Okay. Now I know. Go ahead, Nico.
Yeah, I did some of the cementless, but now I stop. And if you look at as David as mentioned, if you look at the literatures, and there's come out now a lot of literatures in 5 to 6 years follow-up, it's not better. And it is more, you can see the radiolucence on this. And second, we have to be very careful because sometimes it is a hype. Like in Australia, remember, David, it's about a decade ago. It's very popular. There's some design, the Australian design with the 2-pack, remember? But then the complication is much more, and that's why. And now they moved to United States. The most, if you go to a conference everywhere in the United States, oh, this is the, we have to use this as cementless. But again, when you look at that, and if you read the literature, very important is that you have to look at the disclosure. Most of them, they have to declare the conflict of interest. So that we have to be very careful. I'm still strict with cemented, Mojieb.
Hadi, do you use any cementless? Sure, go ahead, Harish.
Let me ask a question to David. Let me play devil's advocate. What is the percentage of failure of TKR among various causes because of the cement bone implant failure? How many of the TKR fail among all the causes like infection and malalignment and maltracking, etc.? How many of them fail because of the cement bone junctional failure?
So I can tell you that
Can you put a number on that?
for me personally, I haven't had a loose tibia from, cemented loose tibia. So I would cement 90% of my knees. But if you look at the Australian registry, the number 2 cause for failure for revision is loosening.
Yeah, but many times
the number 2. So you're talking about 35% of knees on the Australian registry fail from loosening.
Is it in a well done cemented knee, it loosen out? Could it be because
We
of
can't
weak
say
bone?
that. We don't have the data to say is it well cemented, badly cemented. That
Because
I don't know.
wonder, I'm quite sure among the faculty who are there here, there are 8 or 10 people who do maybe hundreds of knee every year. How many of your knee fail because it fails specifically at the cement bone junction? All of you.
None.
Anybody has number more than 1 or 2%? No. I mean, if there is no problem, there is no question, why do we found solution?
Well, I think Ashish, Harish, in morbidly obese patients, young, less than 60, morbidly obese patients, there is a good evidence that these patients are at risk of tibia loosening. So if you're gonna do a cemented, have to make sure you have to use a base plate that has minimal 50 millimeter length, and then the
long
keel has to be cemented.
That's correct.
Otherwise, you have to go to cementless. And this is only one advantage of cementless versus cemented. And in the literature, it supports it. But otherwise, if we look into up to 18 years follow-up, there is no difference between cemented and cementless. And if we look at the cost, how much it costs the system to bring in cementless, I think it does not justify. So I believe the role of cemented is in the younger patient who are morbidly obese. And in these patients, you should be aiming for mechanically aligned knee, because you don't want to do personalized with a varus of 5 degrees, because we know they are at risk of loosening.
Yeah, so Ryan
I have a
Nunley
question
has
for
certainly
David.
shown that in BMI over 40, cemented-less tibia did better than his cemented. That's Ryan Nunley's series. Now, I didn't find the same thing, but you know there are a lot of people now advocating BMI over 40 should put a little cemented stem, as Ali says. So, I think the goalposts have moved. We're now doing total knee replacement in 50-year-olds, right? And I'm not sure that 30 years with a cemented tibia may not be the right thing.
Can I have a question, Mojieb? Is the cementless knees or any design dependent, a tibial component especially, that what Nico was talking about, the two peg tibia, now probably there's a keel tibia and with pegs, etc.
I know that there are different materials. So the older porous design or the titanium mesh or the fiber mesh were the one that had brought a bad name for the cementless knee. And that's why people, I mean, when I was in my training, it was a taboo even to talk about the cementless knee because they didn't do good. Everybody knew that they failed. The failure was way higher than the cemented knee. I think with the modern ultra porous devices, things have changed. They have definitely better fixation, but again, we have to choose our patients correctly. As David said, you got to choose them in young, preferably young male who have very good bone quality. And I think the fixation or the design type of whether with a keel or with 4 pegs, because even those that have keel, they have 4 pegs, but they have more like a spikes rather than pegs. So the 2 or 3 pegs is a particular company design, and the keel with the spikes are a different company design. And sometimes the same companies may give you 2 different material fixations. One will be titanium foam versus an ultra porous device like a porous tensor. So I don't know whether the design alone carries the risk or the type of metal that you're using for this porous fixation. But that will be my explanation for the design. I think the addition of the keel is just to give you more rotation stability, because at the end of the day, the fixation goes to the undersurface of the tibia. Am I correct, David?
Yeah.
Yeah, correct. So, basically, we know that the success of a cementless tibia is very dependent on the early micromotion. So you need sufficient interference of fit, and you need sufficient ingrowth surface.
Can I ask a question, please? David, you do this uncemented knees. Would you be doing their DEXA scan pre-operatively? The bone to know how much is the osteoporosis, if at all you have any of those people. That's a major concern in our country. Even if we have an uncemented knee, we would be worried about the significant amount of osteopenia they have. So will you have that kind of study before you do the surgery?
No, so I don't get a DEXA scan.
David, just 1 second. Rishi, could you sort out Dr. Ashit's why the echo is coming from that side? Ashit, do you mind just muting yourself? Yeah. When you mute yourself, then the echo stops.
I don't get a pre-op DEXA scan. One, I don't actually know how to interpret it to say, can I do cementless or cemented? I judge it on the cut surface of the bone when I've made it. Don't get me wrong, while I'm saying that cementless is an attractive option, I'm still cementing 95% of my knees, right? It's only a small percentage. But I think as technology, our designs improve, yes, people say it's more expensive, but it may not be. It may save time, save cement. It may be, less. Cementing is still very much dependent on cement technique. It's not just a given just to cement the tibia in. So I'm not saying do it in everyone, but I think there may be a role for it. I don't think we should dismiss it.
I have a question for David.
Go ahead.
David, what's going forward? What's the role of hybrid fixation, say uncemented femur with a cemented tibia?
Yeah, again, I on the Australian registry, hybrid and cemented do the same. In fact, hybrid actually does a little bit better than cemented on the Australian registry. But I think that's actually probably a surgeon factor there. You have to keep in mind registries are not just measuring prosthetic performance, they probably measure surgeon performance. And I think a lot of high volume surgeons do hybrid. But yeah, I mean, I don't think there's a clinical advantage, except for maybe you don't have, you're not going to get cement left posteriorly.
Mojieb, what percentage of your knees now cementless knees?
3.5%. That's a percentage I have in my practice, and predominantly will be male, well-built male, regardless of the age. So it's physiologically well-built. And again, the decision will be done once I have cut the femur and the tibia, and then I look at it as David said, and then we'll decide. So I still have my cemented system available, which is my go-to. That's my default. That's my 95% of my cases. In well-built, if I have a well-built male who come to my clinic, I'll just put a note on the booking slip saying, cementless system on standby. So at least they're available. If I think they do qualify, the bone quality is good, I would put it. I think I've only done on 2 females. One was a relatively young lady, 40 something, and the other was physiologically very young. Chronologically, she was 62, but she was really very, very bad. So those two ladies so far, touch wood, they're doing well. They haven't loosened up. But apart from those two patients, I've only done it in male. I don't do DEXA prior to that, and it's a tough call because you got to be very clear. These are almost 3 times more expensive. So when you're putting that much, you're putting that much money in one patient. You hope that this will last long enough that it will overlive the chance of when he will need a revision or she'll need a revision, and that's how you balance it. I mean, it's how much extra money you put in the implant so that you prolong the survivorship, and then you contrast it to the cost of revision if he had needed a revision for a cemented knee, particularly if he was a younger guy.
Correct. Great.
I don't know whether we are having the same discussion that probably our seniors had when the cementless and the cemented hip came over, back in the early 80s or 90s. I think even today people do cemented hip and you cannot fold them. And I think the only question we have is that if cost was not an issue, so let's say, with a different titanium foam, which are probably cheaper than the porous or the more expensive ultra porous device material, would we be then having the same concept or same discussion? Would we be more comfortable doing more cementless knees because the cost will not be an issue? If the cost of the cemented and the cost of the cementless knees are the same, would more and more of us will be doing cementless knees?
True.
I don't know.
Well,
True, at
Mojieb,
least-
I mean, if we look at the implants, not all companies cementless knees perform the same. And we've seen some, companies made attempts at cementless and they failed dramatically and they pulled out of the market. So this is why I think, it's really that this is something that should be really considered, because you could be putting this implant, it's very expensive, and then end up revising it in 2 years and causing more damage to the patient as well. So since till now, we don't have data of cementless outperforming cemented knees. I am not considering any cementless unless I see that data.
I think in the United States, more and more surgeons are moving towards uncemented knees.
Yeah, but they are looking for that 10 minutes, that they are saving, so they could do extra case.
Exactly. Yeah.
But I think even
So
those, Dr. Mohanty, will be, those surgeons, even in the States, would be probably choosing their patients carefully, who will be younger folks, younger male or female. And I don't know whether the cost difference there would be the same as we have in Asian markets. As all those things, I think, do play a role in whether you choose, because again, as Ali said, not every cementless knee systems are the same. It depends on the design, depends on the material that they have used, whether it's ultra porous, titanium formed, different types of materials are there. And unless and until we have a clear-cut data, some systems have been there long enough that you might feel comfortable just because they have been long enough. But that's not a scientific data saying that all cementless knees do better. I think what we may need to look at is cementless total knee performance in patients less than 50. Do they do better than cemented knees? And maybe one of the registries can answer that question. Am I correct, David?
Yeah, I think, no question. We're not going to do it in a 75-year-old. It's the 50-year-olds that we've got some question marks still, because their failure rate is still 30%. Overall, 30% at 10 years. 30% failure rate in the under 60-year-olds at 15 years.
Okay. So most of the time, in our countries, it use depends on the affordability of the patient and availability of the implants. There are two important factors also plays in our decision making. One of the Indian companies, they have started manufacturing, uncemented femoral component only, and some of the surgeons have started using it. We don't know what the future will tell. So
over
should
to you,
we
Dr.
move?
Mohanty.
Yeah.
We'll
So
be,
next we move towards the next, thing that Let's move from primary to revision situations. So sleeves or cones, which one do you use and why? And we know that sleeves has to be used along with the components as a single unit or monoblock units, whereas cones has to be placed separately and then the components has to be placed. So let's start with Ali. Ali, what is your preference? In using
Yes,
sleeves or cones? Or you
thanks.
sometimes use sleeves or sometimes cones?
Thanks a lot for the question. So I like to use cone for majority of my cases, unless if I don't have a proximal stability that I need to go to the diaphyseal, then I like to go with the sleeve. I think you could get better stability with the sleeve, especially in uncontained defects. The sleeve has advantage on that for these kind of patients. The disadvantage of sleeve, because it doesn't have an offset, sometimes it lateralizes the component, especially in the femoral side, and then that causes irritation of the ITB and patellofemoral issues. But I think each one of them has an advantage over the other. So I prefer to use cone because I could use different cone for different implants. So it's not implant specific. But then when I need really stability and I don't have, if I uncontained defect, I don't get really stability from the time of surgery, then I go with the sleeve.
Right. Okay. Vidya, what is your choice? Sleeves or cones? Any specific?
So we cannot use cones in an uncontained defect. So sleeves is the more easier way to do it, and it gives us definitely more stability. But then there is a question of sizing in the smaller size Indian patients, where even the cones or the sleeves, both options may not be appropriate in such cases. But most of the times, yes, I would prefer to use a small sleeve. The smallest sleeve available is a cemented sleeve. Sometimes we need to go with that.
Okay. Have you ever used sleeves without the stem extenders?
Yes, on the tibial side, using the stem just for the purpose of the trial stem, just for the purpose of alignment. But yeah, if you get a good stability with the sleeve, then we can forego the use of the stem.
So that is one of the advantages of using a sleeve, that
Yeah.
especially sometimes on the femoral side when the bow is there, then if you get a good fixation with the sleeve and good zone 1 fixation as well, so you can
Exactly.
get away with the stem. Yeah, David, what is your take on this?
I don't have much experience with the cones. I have generally used the sleeves. That's mainly probably because it's the system I use, which is the Tune, has sleeves. But the one disadvantage of a sleeve, yes, it gives very good fixation. The one disadvantage of the sleeve, because I've never used it without a stem as well, is that the sleeve, you're married to the stem. So your alignment is dictated in a lot of ways by your stem. And I must admit, there is some experts now advocating that perhaps a cone with a short cemented stem might be the way to go, because then you can try and recreate the true joint surface that way without being, I guess, tied to the diaphyseal canal. So it will be an interesting concept moving forward, whether if we truly try to recreate the joint anatomy in a revision, will we get better outcomes than how we've traditionally done revisions? But I have no experience with that technique, but certainly with robotics, and I know Ali probably has a lot more experience with this. If you can really recreate the joint surface like we do with the primary, so you're trying to do a revision like a primary, and then you are then doing a short cemented stem with a cone to get your fixation. Maybe with robotics we can get better results.
Right. So
Yes, David, thanks a lot for that, pointing that out. I mean, this is all my revisions now. Is if I'm not needing to use an augment on the tibial side, I will not use a cone. But if I use an augment more than 5 millimeter, I have to always use a cone and then use short cemented stem. I'm using all short cemented stem on femur and tibia just to avoid going to the diaphysis. and load the metaphyseal area. And with the robotics and revision, it's really working out well because you're building up the joint from the femur with the origin of the ligaments, the collaterals. And this way you restore the joint line better, your posterior offset better. And this is the single most important factor in revisions to make revisions like primary. So I think it's really a nice way to go. And requirement for cones pretty much on all the revisions that I've done, majority of the time it's on the tibia side.
Right. Ashit, do you have any preference of using in any situation that cones?
So again, I think so the indication of using sleeves and cones are slightly different. If we have an uncontained defect, then we need that proximal tibia or the distal femur metaphyseal fixation. Then I use the sleeve. And if we have a good zonal fixation, zone 1 and zone 2, then perhaps we can avoid a stem on the zone 3 in the femoral side because of the bow. So that way I feel the stability is excellent with the sleeve. And if there is an uncontained defect, we can use sleeve very well with the excellent stability. However, cones can be used because there is a flexibility for us to use the cone and use whichever implant, whichever company implant. Sleeve, you are married to that particular debut, revision system. But cone, this is possible that we can do it. So if there is
I think that's a very important point for the cones. Yeah.
Yeah. So that's how, if we have where there is not much of the problem of metaphyseal bone loss, but you want that, additional fixation, then you can put the cone and then you put whichever revision implant you are using in that cone and, just, reconstruct the tibia or femur accordingly.
Correct.
So I think the indications are slightly different. Yeah.
Yeah. Harish, what is your preference of use? Can you unmute yourself, please?
Yeah. If you have to keep only one inventory for financial reason that either have cones or have sleeves, then you should keep cones because they can be used in almost all indications of defective proximal metaphysis of tibia or femur. You can augment that bone which is not there, add additional bone graft, and then cement whatever implant you want inside it. So it is more universal. But in India, they are quite expensive. And the second thing is sleeve become less expensive. And if you don't have a peripheral defect, then sleeve will work very well without any problem. It gives you a biological fixation because these are non-cemented in, except for the smallest size. And there you can get a really bone ingrowth into proximal part. So I presume the long-term survival of a sleeve, which has got a biological ingrowth, will be better than a cone in which you are cementing an implant.
True. Mojieb, what do you use? You use
So
both?
the system I use does not have a sleeve. It's only cone, and my preference to cone is exactly what Terry said. It's far more universal. It gives me the option of alternating and mixing and matching. And there are different sizes and different shapes of the cone. So cone could be used as a central cone. It could be used as a peripheral. So if you have a defect, like Ali said, 5 or more than 5, 7, 10 millimeter, you can use a cone to give you a metaphyseal filling, and you just cement your tibia on it with a short stem, and this will preclude you from using an augment, and that will also give you a very good, nice biological fixation of that cone material to the rest of the proximal tibia. You can do the same thing on the distal femur, because again, you take away your femoral component, and your joint line has definitely been recessed. And if you don't have good condyle cement because you're revising a knee that was done in PS, so the box was already gone, you can then put a femoral metaphyseal cone and leave it a bit proud, and that will give you more like a condyle substitute on which you can cement your augmented femur, or even with no augment. The only drawback in our patient, and I think the same thing applies for India, is the size. So one trick that I do is sometimes I use the tibial cone on the femoral side.
Correct.
I don't know whether I'm allowed to say this off record, but I do that a lot. And the other thing, you can also take those cones and you can slash them. So you can cut them and you can put them, if you have, let's say, an anterior cortical defect and the cone is too big on the femoral side, If somebody has done a big notch, then you can put, you just cut that cone and you put them like a 270-degree anteriorly only, and that will give you a nice cortical bridge, substituting that anterior cortex. So I've done that a lot using tibia on the femoral side.
One of the Indian company, in fact, manufactures this kind of Kambi cone, they tell. It's a cylindrical part, and at the end it is flayed out. So that cylindrical part can go inside the femoral canal. It's very diaphysis. So it can, fill up the either anterocortical defect or a posterior cortical defect. And it sits nicely, snugly fits inside the canal, and then the condyles are shaped like that in order for the fixation of the components.
See, the other thing also that in smaller femur and tibias that we have in Asian knees with the bow, you're almost by default, if you're going to use a diaphyseal stem, you will have to use offset stem. 80% of the time, use offset stem if you're going to use a diaphyseal engaging stem on the femoral side, because if you don't, then most of your components will be anterolateralized. You cannot do that with the sleeve. You have to use the straight stem in the sleeve, and your component will be lateral. That's not a problem with the cone. You put your stem wherever you want. You put your cone wherever you want. If you think that the cone is coming on your way, you can even burr it a little bit or cut it and then put your stem where you need to be. The other advantage, and I don't know whether this is an option in the sleeve or not, is that once you have put your cone, metaphyseal cone, you can cement a short cemented stem, which will allow you to put the component wherever you want it. So you can put it, if you think because of the diaphyseal stem, it's going to push your femoral component laterally, you put a metaphyseal cone, you put a short cemented stem, and that will allow you to center your femoral component mediolaterally, anteroposteriorly, without having to be falling slave to the diaphyseal stem, which will force the component a certain position, which probably will cause you lateral impingement because of lateral overhang. That will not be a problem if you use a short cemented stem on a cone.
Yeah, the sleeve doesn't allow that because it has to be used as a monoblock components, and it has to take the position of the components.
Yeah.
So there will be a possibility of impingement of the stem in the bow of the femur, or maybe tibia. There may malpositioning of the component depending upon the stem position.
Exactly. So that's my concern on the sleeve. But apart from that, I think at the end of the day, whatever you're comfortable with, if your particular case is something you can get away with using a sleeve, and that's what you're comfortable with, then fine. Otherwise, you can use the cone. The other thing is that sleeves are porous, whereas I think the cones are made of ultra porous material of different companies. Some companies also make like a right and left cone on the tibia, so have like a bi-lobe cone. So there'll be like a cone which has a lateral and medial part for right and left tibias, and that will give you a very nice metaphyseal filling.
Anybody has taken out a cone anytime in revisions?
I did.
Okay. How is the bone on growth on the cones? It's a nightmare.
It is a nightmare. It is a nightmare. But you got to do what you got to do. But the trick about it is that you just need to go correctly with the interface. If you find the right interface and use your curved osteotome, just go gently. You might lose a little bit more bone, but the question is that cone needs to come out if you're dealing with an infected case. It has to come out. You got to take it. If you use a burr, I don't know how successful you will be, because it will give you cone material flying all over, that your operative field. So I think an osteotome is a better option than using a burr.
Okay. So I think we had enough of discussions about this topic. Now over to you, Mojieb, for the stem options. We have Dr. Ashish Phadnis with us, our Secretary of Bombay Orthopedic Society, and he's also himself is a excellent arthroplasty surgeon with a lot of revisions also he does in his practice. Welcome, Ashish. So you can take part. You can take part in our discussion, so you're welcome.
Yes, so I think our next discussing point is the choice of stem options when you're doing either a revision knee or a complex primary knee. Do we go to the long diaphyseal stem, or do we go to cemented stem? What's the audience preference, and do you have a preference for a particular stem, and when and why? Or if you use both of them, then when do you use one over another? So I'll start with Dr. Ashish Phadnis, since he just joined us.
Hi, sir. Apologies for joining in late. So, my own practice, the use of stems is very less, unless it's in a very morbidly obese patient and who also has a risk of a stress fracture in a primary situation. Yep. But the implant that we use generally has a slightly longer keel and a longer stem, the Genesis 2. The modern implants, the Anthem has a smaller one, but yes, it will be a sort of an uncemented stem just to give it a slight stability. But otherwise, my
So,
experience is very less in using
so,
the cement stems.
so for all the faculty here, if you're using a primary knee, what do you cement your tibias, or there are special situations when you cement the tibia, and when would you consider cementing a tibia?
Yeah, so
Dr. Raut, yeah.
I would almost never cement the stem fully in any situation, because it would be a nightmare to take it out if it comes to it. We got to have fixation in two zones. So good condylar cementation and a metaphyseal fixation is enough. The stem serves just to prevent a toggle. And I would not,
So
as
those you're
Ashish
talking
said,
about the long diaphyseal stem, but usually the cemented stem are short metaphyseal stem, let's say 30 millimeter or 40
yeah,
millimeter.
I mean, if I use those, then I have no qualms in using in cementing it fully. But many a time, for especially for obese patients, sometimes you have to use a longer stem, and I would not cement the whole length of the stem.
Okay.
So
Shah?
most of the companies, they have two versions of the stem. One is the short cemented stem, and there is a very specific indication for using this particular stems as compared to the longer stems which we normally put for obese patients, osteoporotic patients, or patients who have metaphyseal defect and we've reconstructed their proximal tibia with either bone graft screws or augments, whichever. So those are the longer uncemented stems where the additional stem that you attach to the tibia, that portion is never cemented, and they generally are made of titanium, which are stiffer material as compared to cobalt chromium. Short cemented stems are something that where you need that initial mechanical stability, but they need to be cemented well. So that should be just take as a part of the cementing of the tibial implant. That should be cemented. The whole thing should be cemented together. So that's why it's a short cemented stem versus longer uncemented stems.
Okay. David, your choice of stems, either in primary complex or revision?
Complex primary, I will cement generally because it's generally smaller, shorter stem. I agree. I think if you're going to cement the stem, you've got to cement it properly. So if I cement a shorter stem, I actually plug the canal and I retrograde the cement like I would with a femoral canal in a hip. Right. So I don't just lay the cement on the component. I actually will plug the canal and retrograde cement into the canal and then put the component in. And same on the femur if I do a short cemented stem. But generally in revision, I'd use a longer cementless stem. Diaphyseal engaging, because again, if you look at the number one reason for revision after revision, it's loosening. So fixation is the number one problem in revision knee replacement. So if I have no zone 1 fixation, then I will tend to go longer cementless stem with a sleeve or a cone. So generally a sleeve. The only time is if I happen to have a long hip stem that doesn't allow me to put a longer stem, or deformity, then yes, then I'll use a shorter cementless stem. But I think in that situation, again, I plug the canal and I cement it like I would cement a hip stem.
Ali, your choice of stems?
Yeah, so for primaries, I use one base plate that has a length of 50 millimeter, and I cement the keel entirely. This way, I don't need to check patient's BMI, and it's solid, stable. And to
Is
remove
that
it is
50
not
millimeter
difficult.
stem, is it a cemented stem or uncemmented? The 50 millimeter on top of your keel length?
It's a cemented stem. So I'm using, if I'm going to use just brand, so it's a Genesis 2 or a Journey base plate, has a length of a primary that is 50 millimeter. and I put cement on the implant and on the bone, and I just push it finger. I don't try to put a plug and cement it that way. But for the revisions, I do it exactly like David said. You have to get 2-zone fixation. In the past, I used to get the FCL and into the epiphysis, but the epiphysis a lot of the time is soft, and we see those loosening. So this is why I switched now entirely to using zone 2 and then short cemented stem. And I put a plug and I cement it just like how we cement a hip. I do the same thing with the tibia and femoral side. So generally I use a 100 millimeter stem, and on the tibia side, almost always I add a cone, short cone, 18 millimeter.
Jayesh, your choice of stems.
Most of our patients are female. About 70% of my primary needs are female. And when they come for revision, many of them have got very osteoporotic bone. I used to use a lot of long stems for revision in the past, with cementing only in the metaphyseal area, and the entire stem was non-cemented, but need to have a scratch fit in a distal shaft. But I found that at least about 10 to 15% of these patients, when I use a long non-cemented stem with a scratch fit in a somewhere like a middle shaft of the tibia or a femur, they get a tip pain. And then it is difficult, because if they get a pain in the tip of the stem, which is very long, there's nothing much you can do about it apart from giving them maybe osteoporotic treatment and some injections, etc. So now I use essentially a small cemented stem, which could be 30 or 60 millimeter long, depending on the amount of defect. And as David has mentioned, I use a cement plug, I cement retrograde, and like I do a cementing THR, I do cementing here. And since then, that problem has become almost non-existent.
So is that in revision or in a primary complex?
If it is a primary complex, again I use a small cemented stem. It could be 30 millimeter stem, but small cemented. I don't like to use a long cemented stem which engage into the medullary cavity unless the patient is very young and the bones are very good quality. Because about 10 to 15% of my patient used to have the tip pain, and then I can't do anything about it.
Okay. Dr. Mohanty, your preference of using stems.
I think now we are moving more and more towards cemented stems. And the primary situation, as Harish told, I use a short cemented stem now. And in revision situations, unless I require badly a diaphyseal fixation, so to get a 2-zone fixation, like Dickey Jones, whatever he has suggested, I prefer to use again a cemented stem nowadays. I saw in 2 of my patients who are getting, the pain in the tibia, and there is a cortical hypertrophy, and even one of the patients, there was a impending fracture I had to revise because of the stem. So now my take is that I have to move towards the cemented stem. If it is revision situation, I can use a 60 size stem and cement it, put it. So another important point is that when you engage the tibial stem in the diaphyseal region, that affects the positioning of the tibia as well. So we may have to sometimes undersize the tibia, otherwise it will overhang in either medially or laterally. Most of the time it's laterally, it overhangs. So that becomes a difficulty. So you have to undersize the tibia. So
I use an offset stem.
Offset stem.
Yeah,
Offset
so offset, but offset stem is not available in every system. Every
Okay.
system doesn't have a offset stem. So whenever the system allows, like GMR allows, so I use the offset stem.
So,
Would it be
Mohanty,
fair
if
to
I can
say?
ask a
Go
question,
ahead.
yeah, sorry, Mohanty. So, if there is a choice between using a short cemented stem versus an available offset stem, uncemented, what would you prefer?
Right now, I'll prefer a short cemented stem.
On the tibia and femur both? Or
Both.
Dr.
On
Ra's question is, okay.
on both
Would it be
sides.
fair to say that on the tibia, I think more and more folks are moving towards using a short cemented stem in primary, short to a little bit longer cemented stem in revision, maybe with a metaphyseal cone or with a sleeve. I don't know whether you can use a cemented stem with a sleeve or it's only cementless. I have no idea because I don't use sleeves. On the femoral side, obviously you have the option of either using a short metaphyseal cemented stem, which is straight, and you choose the position of your component, or you can use a long diaphyseal engaging stem, but you should only use them if you do have an offset option, because that will allow you to position your femoral component both in coronal and sagittal plane to your preference. The question is, do you have a different cementing technique if you're using the short cemented stem on the tibial side, which I think is the predominant practice now of all of the faculty in the panel? Would you be using that in primary situation versus revision situation? Would you use different cementing technique? So
Ashit,
plug
could you
and
please,
pressurization.
Ashit, could you please mute yourself? Whenever you
Yeah.
talk, only you open it because there is some echo coming.
All right.
Yeah, sorry. Yeah, Mojieb, please continue.
Is that a fair? So the question is, if we're using in a primary complex situation, do you use simple, packing the cement with finger on a short cemented, versus if you're going to use it for a revision situation, would you then be using a plug and pressurization and a cement nozzle? Question to all the faculty. Maybe Harish and David can comment on that, and then we'll ask the other faculty.
Yeah.
David,
Anytime
in the revision, yeah, go ahead, Harish, go ahead.
Anytime I use a cemented stem, it has to be cemented well. Just a little bit of finger packing would not work because it doesn't give very good stability. So I have to use a cement plug, do a good cementing, and then it will last very long.
Okay.
Small or
Regardless whether
large.
it's primary complex or revision. Okay.
Yeah.
I'm the
David?
same. I'm the same.
Okay.
I plug and cement.
Ali? Okay.
Yeah. So for primary complex, I will use the same as the short metaphyseal fixation, cement plug, and cemented.
Okay. Dr. Mohanty?
I don't use gun and syringe and plug while I cement the stems. I just do finger packing of the cement and pre-coated implant, then you put it on that. I don't use gun and syringe and do a THR like cementing there.
Okay.
And,
Dr. Raut and Dr. Shah, if you guys are going to use a short cemented stem, would you finger pack only, or would you use a full pressurization technique?
Just like Mohanty, I mean, I would finger pack. I would not use a plug and and gun. Finger packing works well most of the time.
So same here, finger packing and making sure that there is cement on the bone and cement is on the implant as well. So cement at both the ends and then really pressurize it well. So generally that doesn't, because there is the cavity is quite short. So perhaps just putting a finger pack should suffice.
All right. And if you're using a diaphyseal engaging stem, would you cement up to the stem keel junction? Is that fair to say? Is that what? So essentially, although we call it cementless, but technically it's hybrid because you have cemented the proximal, the tibia keel, and then the rest of your stem is uncemented. Do you put a stem at the tip of the stem only? So if you're using an uncemented stem, do you put some cement at the tip and the cement at the keel, like a modified hybrid technique, which has been described in some literature?
No. So what I do is pure hybrid when we have to have that particular kind of fixation in a revision scenario. So put the cement around the tibial keel and stop where the stem is actually screwing in onto the keel. And so the longer portion that goes in diaphysis, there is no cement and there is no cement at the tip. But I make sure that my canal filling ratio is very good. The diameter of the canal of the stem and the diameter of the tibia or the femur, as the case may be, should be less than 1, but very close to 1. So 0.85, 0.9, though it's a post-op radiological thing, but I make sure that, I have a good cortical, scratch when I'm preparing the bone.
So that's a CFR ratio of more than 0.8 to 1. Okay. I have a question from Dr. Baviskar. Yeah, go ahead.
Yes, sir. So I wanted to ask, in our Indian patients, especially very short patients, when we do a lot of reduction osteotomies to balance the knees. So now if you use a even if you use the smallest 30 millimeter keel, which is cemented, it might impinge on one of the cortices. So is there a way to, prevent this, or how do you manage these things?
Yeah, that is why, you prefer to use a small 30 millimeter stems in case of small Indian females. We prefer to use. Then that is available even with 1.5 tibia. We have, small cemented stems because of this impingement, to prevent that impingement. And sometimes the canal is very narrow, where you cannot even put the smallest size of stems. Some of the Indian manufacturers, they have come up with a 8 millimeter, stem extenders. Even 7 millimeter stem extenders are available. But we don't know what's the long-term outcome of this small, very narrow, small stem extenders. That's why I prefer in those kind of situation, put a small 30 millimeter stem extender, cementing it.
I
Well,
think
this reduction of the steotomy technique, you go with a smaller size, and then 30 millimeter in the slim patient will be enough, sufficient. But if the
Exactly.
patient is obese, then my advice is go with the 50 millimeter primary base plate cemented and cement the keel. And you could do finger packing here for this primary base plates, but cement the keel in these situations because the bone is very hard proximally, and you need to really engage the metaphysis and make sure that it is really cemented nicely in the proximal metaphyseal region.
Well,
I
Mojieb, we
think
have to be a little faster
Yeah.
because
So
we
in
are running
conclusion,
short
I
of time.
think both cemented and cementless options are viable. You just need to know how to do them well, and what will be your choices. I think more and more people are walking away from using cementless stem on the tibia to avoid the points that Dr. Bende mentioned, which is the end of the stempe, and therefore cementing the stem on the tibia, maybe using cementless or cemented stem on the femur. I'll move over to you, Dr. Mohanty, for the next
Yeah,
discussion.
we have two quick topics to cover. So first thing is that next comes the anticoagulation, that whether you prefer a low molecular weight heparin or a newer oral anticoagulant drugs like rivaroxaban, apixaban, or you still prefer also the age-old ecosprin, and for how long? For the knees post-operatively in primary or revision situation. So let's start quickly. We will have only about couple of minute discussion on this. Then we move on to the last topic. So David, what is your protocol in Australia? What you're following?
I give Clexane or Noxaparin while they're in hospital. Starts 4 hours post-op, ceases on discharge, and then BD aspirin, 100 milligrams BD for 6 weeks.
Okay. And
I give them esomeprazole to cover their stomach.
Right. And do go away from this protocol for any other special cases, or patients who have a history of say cancer, or a patient who has a history of DVT, history of any varicose veins, or any obesity?
So patients had a previous DVT or PE. I normally get them to see a hematologist, and they will always recommend rivaroxaban or apixaban. So then I follow their instruction.
Okay. And Vidya, what is your protocol? Do you give in each and every patient?
So yeah, each and every patient. So for one night or maybe 2 nights, if the patient is in the hospital, they are on Clexane, and when they go home, they go on either apixaban or rivaroxaban.
And how many hours after surgery do you start collection or low molecular weight heparin?
Minimum 6 weeks later, 6 hours later.
6 hours later. Okay. Harish, what is your protocol?
I think we don't have an actual real answer about what we should do. We're trying to fight between avoiding any medical allegation when somebody gets DVT and trying to prevent complication of bleeding. So what David told me is quite right. That's what we do. In hospital, any kind of like Clexane we use, or any injectable LMWH we use. And when they go home on the second, third, or maybe fourth day, they go on ecosprin 150 milligram once a day for 6 weeks. And we encourage more on a mechanical way, like we give them DVT pumps In a hospital, we encourage them
Yeah,
to
those are,
stand and walk immediately. And we tell them that if you do that, risk of DVT is much less, which is actually true.
yeah. Ali, what is your protocol in UAE?
The same as David. The only thing, I don't give Clexane at 4 hours. I give it after 12 hours.
Right. And for 6 weeks, Ecosprin?
No, so the aspirin is 100 milligram BID for the knees 2 weeks, and for the hips 1 month.
Okay. And Mujib, what is your
We give
protocol
rivaroxaban 12 hours after surgery, 10 milligram, or apixaban 2.5 BID, 14 days after surgery for total knee, and 28 or 30 days for total hip.
Are you worried about rivaroxaban? There is some, it is told to be little unsafe in presence of hepatic or renal problems, whereas
Yeah, so if we have
apixaban is more safe to give
Yeah, so
in
so
this kind.
for those patients, if patients do have renal issues, the rivaroxaban or Clexane doesn't work, then they need to be given 5,000 heparin, simple heparin, the 5,000 BID sub-Q for those the renal patients, you can't give rivaroxaban or apixaban.
No,
Or even
apixaban they tell it's safe, quite safe for the, it's nephro.
So we consult our nephrologist, and depending on the renal pathology, they will either recommend a 5,000 BID sub-Q injection of heparin or apixaban, depending on what the renal pathology is. I think it also depends on what CKD stage you are, either stage 2, 3, or 4.
Okay.
So we take their input.
Ashit, what is your protocol?
So when I have a case where it's only spinal has been given, the first dose of Clexane goes 6 hours after the surgery is complete. If patients had an epidural, then I delay this by another 6 hours. So the first injection after of the Clexane will go 12 hours after the epidural has been inserted. And while they are in the hospital, we give them the Clexane. And again, when the epidural is going to come out, make sure that 12 hours before and after the injection is not given. Once they are converted into oral, 3 weeks, Ecosprin 75 milligram works very well. And if it's a total hip, it's about 1 month. And along with
So
this,
75 milligram daily.
Daily
Yeah.
for 3 weeks for a total knee. And for THR, it's for a month.
Okay. Ashish, any different? Could you unmute yourself?
Yeah. So we give Clexane on the day of surgery, and once the epidural catheter and things are out, then they're converted to rivaroxaban.
Okay. Any particular reason why you prefer rivaroxaban? Though now Ecosprin is told to world over the literature, so it's quite safe to give Ecosprin, which is cost effective as well.
We have to shift to rivaroxaban, but I practice in a place where there are 3 or 4 more arthroplasty surgeons. So it's basically just for the sake of convenience of the entire team, the residents, the anesthetists, everyone is on the same page. So as Dr. Bende mentioned, we are in between cardiologist, litigation, and getting a DVT. So we are still not moved to Ecosprin, but we are seriously thinking of changing the entire practice, all of us.
Jayesh, any different?
No, sir. The same. We use Ecosprin, not rivaroxaban. But in during admission, we give them Clexane. Post-operatively, it's Ecosprin only. Unless there is a high risk, then we shift to what the cardiologist say.
Okay. So to conclude that most of us that prefer to give, low molecular weight heparin about 6 hours or 12 hours after the surgery till the patient is in hospital, and during discharge, we discharge with the Ecosprin for about, say, 4 to 6 weeks, depending upon the hip or knee. I think that is a consensus amongst us, and that message should be given. Now over to Mojieb for the last,
Yeah. So this
choice.
is a rehab related question, which is basically, patients in our part of the world, Asian part, Middle East, Far East, are very much focusing on flexion. That's what most of their questions will be once they come and discuss total knee replacement. And I think the physical therapists also focus on that. But during your follow-up, particularly at 6 weeks, 7, 8 weeks, you do notice that although a lot of patients would have gotten reasonable amount of flexion, some of them would have not being able to achieve full extension, 5-10 degrees of flexion contracture. And which will be concerning you more? Would that be the loss of flexion or the fact that they did not achieve the expected flexion by 6 weeks versus not being able to achieve the full extension by 6 weeks? Start from David.
So for me, loss of extension is much more of a problem. My patients don't need high flexion. None of them squat. They're all big. So they want to be able to walk well. And if you have fixed flexion, it's a very inefficient way to walk and they fatigue very quickly. So I don't worry about flexion at all in the first 6 weeks. I really get them to work on passive extension stretches in the first 6 weeks. But for me, it's about pain control. So they have to have swelling reduction, pain control, and I don't get them really to do much flexion in the first 6 weeks. It's more about extension. But if they don't get their extension back by 3 months, it's very difficult. You can't manipulate it. It's not possible. So then it becomes a wait. And if it's really a problem at a year, you're really looking at revision surgery. So no, for me, it's extension.
Before that, may I add that does your approach also, takes an important role like subvasters or parapetlar or midvasters approach to gain the extension or recovery of the quadriceps? Just you can add in the discussion. Yeah.
I'm sure. Look, I have no experience with subvastus. I'm thinking about it, but I haven't quite made had the courage yet to do it. I'm sure they recover their quads much quicker with a subvastus approach. But I guess, it's not so much about active extension for me, it's passive extension that I get them to do. So I think there might be some benefits. I have no experience.
Dr. Roth?
Yeah, the problem with the physiotherapists in our part of the world is that their parameter of success is how quickly and how much bending they can give to the patients. And we have to be after the physiotherapists that don't focus on flexion. And as David said, we need to get active extension without a lag as quickly as possible. And that's important. The quadriceps strength, work on the quadriceps strength is important.
Ashish?
Yes, sir. So extension, not getting an extension is a big problem. All of our unhappy outcomes have been the patients who have not got an extension landed with a flexion deformity. So there are ways to subvert or convince the patient that a loss of flexion probably is acceptable. Not acceptable, but can be manageable. And in the counseling, we tell them that they might lose a little bit of flexion, plus minus 10 degrees. But extension is something that they would not tolerate. Loss of extension is something they don't tolerate.
Neeraj?
I think it's quite right. We have to get extension right. If you don't get good extension, they cannot walk very well. They get a lot of pain. They get a suprapatellar pain and they are not happy. Less flexion, they won't be very unhappy like people who don't get full extension. So always extension is more important, no question.
Dr. Shah?
Yeah, so getting extension is important because first of all, as discussed, it gives good posture to walk. And secondly, if they are walking with slightly flexed knee, they have not got full extension, they can stumble and fall. So that's something that, in the rehab, we have to be very, very careful that if you have some patients where they are able to extend passively, but not actively, mobilize them with a short knee brace so that they don't break and they don't fall. And once they are off, remove the brace and they can get going with the training for the quadriceps, VMO, etc. So again, getting extension is very, very important, and that gives the initial stability. Flexion can come slowly over a period of time.
Ali? Dr. Belooshi?
Yeah, I agree with the faculty. Both are very important, but extension is more important. And I think with the robot that I'm using in all my cases, I make sure that I get full extension on the table.
Ashit, please mute yourself.
Yeah, sorry. Like
Sorry again.
No problem. No
So
problem.
both are very important, extension, but more important, just like what the faculty said. So in the theater, very important for me that I make sure that they have zero extension, so full extension. And if I don't achieve it, I try to take 1-2 millimeter more of distal femur, but not more than that. And then a lot of it has got to do with posterior capsular release, posterior osteophyte release, and on table, I have to make sure they have full extension. I know flexion they will achieve because a lot of our patients, they come with full flexion. So achieving flexion is not too difficult. And we know preoperative range of motion determine postoperative range of motion. As David said, pain control is very important. So we rely on our LIA and also our anesthetist give adductor canal block of Exparal. And I think Exparal really works well when it's done by anesthetist rather than depot of multiple LIA injection. It doesn't work as well as when it's injected around the nerve. So all the Exparal is done by anesthetist, and he mixes it with 10 cc of morphine, and he injects it with the ultrasound guided around the adductor canal. And that really gives the patient good 3 days of relief, and they achieve full extension and flexion of 100 during hospital stay. And we teach them after, like, I mean, here we have the habit of prayer. So I tell them they have to do active assisted extension and flexion by themselves, 10 minutes every day after each prayer. And that works very well. Education is very important, and good pain control.
Dr. Mohanty, anything extra
Yeah,
that you would like to add?
no, I agree with all of them, but it's just I just wanted to ask one question that do you put any knee brace post-operatively in your patients
I do.
till
I
you
put
get it?
them. So our protocol is that every patient after total knee gets a brace whenever they are sleeping or lying down, even if they're lying down, just taking rest after lunch. And they need to keep it on for minimum 4 to 6 weeks till we are happy that they're able to get active extension. Because I think as Dr. Rao said, that patients and physical therapists are so much preoccupied with flexion and working on the flexion that they completely forget or overlook the loss of extension. And they might overlook 5 or 10 degrees, thinking that they'll get it sometimes. And then, here you are at 8 weeks, 10 weeks, they're almost gone into fixed flexion contracture. You have a very good flexion, 120, 130, but then you're stuck with 10 degrees of flexion contracture, and it could be late. I mean, you don't get them by putting them through manipulation. You can take them to OR for manipulation to get more flexion, but you can't get them. You can't get your extension that they lost by manipulation. So
That's right.
David,
that's the reason we put this point for discussion, because a lot of even patients themselves, the only question they'll ask you, can I sit on the ground? Can I pray? Can I squat? And they will focus on that. The therapist will be kind of, I don't know whether by themselves, by patient
Exactly.
pressure, and then you end up with a flexion contraction. That's something we have seen a lot in our practice.
Yeah. David, do you put a brace post-operatively?
No, in general I don't. If I'm worried, I will. Some patients like to lie with their leg externally rotated and the knee flexed. Then I will if they have that habit, but it's pretty rare. Again, I use a robot, so I like to know I can achieve full extension before I close the knee. And I get the patients 3 or 4 times a day to do dangle their leg insofar as they put the heel on another chair and they have nothing under the knee, and they try and just let their knee drop into extension with gravity. So I get them to do that 3 or 4 times a day. And once they get a bit more comfortable, I actually get them to hang a weight off their thigh and their shin bag, and they put a weight inside the bag if they're not getting that full extension, just to give them some passive extension. But knee splint, generally no, because my patients don't tolerate it very well. Once they go home, they won't wear it, I know.
Yeah. So I agree with everyone that, loss of extension, one should focus during the post-operative physiotherapy rather than flexion. But flexion will come eventually, and you can do something about it. But unless he gets extension, then it becomes a difficult. Patients are dissatisfied. Chances of fall is there. Yeah, Jayesh, you.
So I wanted to ask whether if you're not using a drain and then there is a slight hematoma, which actually you got a complete extension during a surgery, but now because of the swelling, the knee goes into slight flexion. and it is difficult to achieve that complete extension. In that cases, is there something that you do to aspirate the knee, or you allow the normal physiotherapy to go on?
I think we'll
If you're
allow
not using
normal.
a drain, if you're not using a drain post-operatively, and you've
Yeah.
used just tranexamic acid, and then now you see that because of the swelling in the knee or the hematoma, the knee is in slight flexion, though you have achieved complete extension during the surgery.
So if I can answer that.
Yeah.
Yeah. So if you have not used a drain, which I don't most of the times, I mean, it would be very risky to go in again and aspirate or drain that hematoma. I would rather wait, put ice packs. I would put a pillow under the heel so that mechanically tries to extend the knee. I like David. I don't like to use a brace except in rare situations. But most of the times that hematoma, to answer Jayesh's question, most of the time that hematoma would settle in a couple of days or a week or so.
Exactly. If there is a huge hematoma, then you could stop the, your whatever blood thinners, whatever you are giving antiplatelets. Yeah, Ashit.
So generally, my observation is if you put a drain, then it will keep draining. And then once you remove the drain after 12 hours, there are chances of hematoma. So if you don't use the drain and believe in that the whatever little blood is collected will give pressure on the smaller capillaries and it will stop. It's like a tamponade effect. So if you are not using the drain, I've stopped using the drain for almost last 10 years. Very little incidence of soakage or hematoma collection, etc. So generally that is not a problem. But what Dr. Baviskar asked, and if that situation happens, be conservative. Don't put the needle, don't try to aspirate, just give cryotherapy, that's ice pack and some anti-inflammatory and maybe brace so as for the hematoma to resolve. Don't try to put the needle and then try to get the extension. It'll happen, eventually it'll happen.
I think we have to call it a day. Mojieb, anything else?
No, I think we had a wonderful hour and so of very
More than that, 1
fruitful
hour 40
discussion.
minutes.
But it was fun. It was very, very interesting discussion. I think we all enjoyed it. I hope the audience enjoyed it as well. Definitely, we learned a lot from each other, and I hope that our audience worldwide have also learned with the discussion that we had. So thank you very much on behalf of myself and SICOT. Dr. David Liu is the current head of the knee specialty committee of the SICOT.
Thank you. Thank you, Mujib. I think I have been troubling you a lot for the last so many months, 3 months to decide about the topics and how to go about it. Initially, we thought of topics, then we thought of case presentation. Then Mujib actually suggested let's have a discussion only, on various topics which are really, helpful, which will be helpful for our faculty. Thank you very much, SICOT and President Dr. Vikas Khanduja and Dr. Margaret Folk, our education chair of SICOT, to permit us to conduct this joint meeting. And Mujib is the immediate past chair of the knee orthoplasty subcommittee. And at present, David is the chair of the knee orthoplasty subcommittee. Thank you, David, for being here the late night, it past midnight, I think, in Australia. And you have been keeping awake and, generating
Thank you.
discussions. So kind of you
Appreciate the
to join this.
invitation and the chance to participate.
Thank you. Thank you. We thank Professor Nicholas Buddhipharma, who is on a flight in spite of his travel that he joined for some time and generating discussions. And thank you, Ali. You are still traveling, or you have reached home?
Well, thanks a lot. This was amazing. I just reached home, so thank you guys for keeping me alive.
Thank you so much. With a long operating day, you are still joining from the car and just talking to us and for taking part in the discussions. And we thank our Bombay Orthopedic Society faculty also, especially our president, Dr. Gautam Zaveri. Unfortunately, he had some personal problems and couldn't join today. And we thank Dr. Rujuta Mehta, who is the chairman of this worldwide webinar, who has to leave because of some personal commitments. And we thank Jayesh Baviskar also for coordinating this event. And we thank our faculty, Dr. Harish Bhende, who is very senior orthopedic surgeon. In spite of his busy schedule, he could manage to join today and, could generate discussions. Thank Dr. Ashit Shah. Thank you, Dr. Vidyanand Raut, for joining today and devoting your time. Now I hand over the proceedings to our Honorary Secretary of Bombay Orthopedic Society, Dr. Ashish Phadnis, to give concluding remarks. Thank you and have a good night.
Thank you very much, sir. Thank you very much to all the faculty and especially our colleagues from SICOT, Dr. Mojieb, Dr. David Louis, Dr. Buddhipharma, and Dr. Ali. I would also like to thank our Bombay Orthopedic Society faculty who have joined us and spared time. I'm apologies for joining late. The whole idea about this webinars was that our Bombay Orthopedic Society is in a 60th year of our existence. And therefore, we had this idea about collaborating with various societies and bringing the best in academics to our members and our brethren in orthopedics all over. So with that idea, we have started this idea about worldwide webinars to be done once in a month. So far, they have been with the pediatric societies, the oncology societies, Journal of Bone and Joint Surgery, World Association for Infection and Orthopedics and Traumatology. But I must congratulate you, Mohanty sir, because we've got faculties from such varied time zones, right from Saudi Arabia to Australia, and faculties from so many different countries coming together. These webinars will stay on our YouTube channel. They would be on Ortho TV YouTube or Ortho TV channel as well, where they can be accessed by almost 19 to 20,000 orthopedic surgeons worldwide, and they would sort of gain views over the few days as we keep on advertising them. We are very thankful to Ortho TV, Dr. Neeraj Bijlani and Dr. Ashok Sham to have supported us in all these ventures. And of course, thank you to Rishi, who is coordinating all the audiovisual today. And finally, a thanks to our academic sponsors from Torrent Pharma, who have been very gracious in helping us organize. I thank you all very much again from the members of the Bombay Orthopedic Society on their behalf and from our behalf. Thank you very much. And we hope to see you again. And next month, we will be there with another worldwide webinar with a different orthopedic society. Thank you very much, sir.
Thank you very much.
So good night. Looking forward to meeting
Thank
you
you,
in some way.
Thank
Some
you.
meetings.
Good night.
Yes.
Thank you
Bye-bye.
and good night.
Thank you.
Good
Good
night.
night.
Bye-bye.
Good night.
Bye.
Bye.
Good
Bye-bye.
night. Bye-bye.
Rishi, you can stop recording.
Okay. अच्छा हो गया.
अच्छा हो गया. Very well conducted.
Yeah.
And the discussion was a good part rather than lectures.
Yeah.
They are
You
recording
know, मैं actually बोल रहा था topic ही नहीं case presentation will do, but ये Mojieb बोला नहीं we'll have discussions only like this, which will have a very interesting.
No, this was just like a panel discussion we have in our conferences, one
yeah.
particular topic and then ask all the panels. So that was
Yeah.
good. This is good. Panel discussion always are more, I think so, good.